here's
Yeah.
how we get more high quality volume into the market to help fill these roles
Yeah.
because that is something that is driving health recruiters at hospitals and health systems to fill these, like, not just primary care roles but specialty roles,
Yeah.
because that's what keeps different wards and hospitals open and everything.
Hey everybody, welcome to the TIMGA Podcast. My name is Mohamed Khalif. Today I'm joined with Eli Greenspan. He is the policy advisor at Foley Hoag. Eli advises clients on policy and legislative strategy work, and his main issues that he works with clients on is Medicare coverage, Medicaid access, pharmaceutical reimbursement, diagnostic development, healthcare workforce issues, and issues impacting seniors and individuals. Eli, welcome to the show, man. Really excited to have you here.
Thanks so much for having me. Excited to be on.
Of course, man. I know you reached out a couple of months ago, and we had a really great conversation on some of the IMG work and with the physician shortage and some of the workforce issues around the country. And I know you spoke with a lot of different organizations. Project IMG was one of them. So just before we get started, tell me a little bit about yourself, man. How did you get? Are you a lawyer by background? What's your background? How did you get into policy advocacy work?
Sure. Yeah, no, sounds good. So, yeah, I usually have to have a disclaimer at a law firm that I'm not a lawyer.
Okay.
And so I do policy and advocacy work here. And I got started in this space by working on Capitol Hill with a senator from New Mexico named Martin Heinrich.
Mhm.
And as a kid growing up in the Chicago area, working for a state like New Mexico, you see the challenges around rural healthcare and how access is a major barrier to outcomes. And so that really resonated with me in some of the work that I got to do for Senator Heinrich. And when I left the Hill, and there was a constant theme in working with hospitals and health systems around workforce shortages and the access challenges that are posed by that, and the uniqueness of rural and underserved communities and attracting talent to those areas. And about 6 years ago, I had the pleasure of starting to work with a group called Physicians for American Healthcare Access. They're a group of largely Indian physicians who came to the United States on a Conrad waiver or national interest waiver and are advocating for changes to the Conrad 30 program. And so that started this awesome path that I've been on of, one, articulating the solutions to addressing workforce shortages, but also working with groups big and small from all across the country, understanding how they're looking at addressing local issues that are impacting providers and patients in their states. And so international medical graduates, that is the umbrella that has guided a lot of my work on health workforce shortages. They make up over 20% of the US health workforce, and millions of patients on different payers depend on these providers to keep them healthy and keep them out of hospitals. So that's a short, long version of sort of how I got into this space, and happy to chat more on some of those issues.
Yeah, man, that's a great insight that you said. Like, especially like here we have basically a policy that allows IMGs to work with another physician in practice, and so we've seen that most IMGs, like, because there's no mandate to work in rural areas and underserved areas, but most IMGs want to go there. They'll pack up their whole stuff. They'll sell their house. They're like, hey, like, I just want to practice my craft. I just want to I don't care how much money it is, and I just want to go there. And you'll see, like, and most of physicians practicing in rural areas are IMGs. Did you notice that in your community growing up?
Yes. So I noticed it in a number of different ways. When I would be in I used to travel up to northern Wisconsin as a kid, and the times that I had to go to a doctor or someone had to go to a doctor, it was usually an IMG, or it was the IMG that's been there for 35 years that is the doctor in town that everyone knows. And so that's the experience that I uniquely had as a kid, but now I hear that story over and over again, whether it's from the providers themselves or from the indirect stakeholders that I try to pull on these issues to sort of understand how they see the issue too, which is it's really reinforcing of how important IMGs are to the U.S. healthcare system.
Yeah, definitely, definitely. So speaking of that, Eli, when you go to the Hill and when you speak with different lawmakers on this issue of, hey, like we don't have enough physicians and there's very talented docs around the country that we could be utilizing. What are some of the things that you hear from? Are people educated down there? Do they know, like, hey, why are we having the physician shortage? And so what are you hearing?
Yeah, that's a great question because it's a constant thing in my head that I'm trying to think through and understand what is the level of understanding of the problem.
Mhm.
There's a commonly cited figure that really helps to frame the issue, which is there's approximately estimated over the next decade a shortage of 86,000 physicians in the U.S. And that figure helps to frame the issue for a lot of people. But it's getting past that figure and getting to that local issue of not just how the problem manifests and what it means for patients, but how you can be leveraging solutions and the pipeline that exists to rapidly address these shortages. And so I tend to talk about not just one solution, but three or four.
Yeah,
And I think that by talking about three or four, and so that's the sort of the IMG pathway, and it's talking about Medicare reimbursement issues, which are chronically underfunded, and then it's talking about the graduate medical education training pipeline.
no,
And so when you talk about, let's just talk about those three, and you set out the timeline for what that looks like. If we invest in GME, it may take 10 years before one of those physicians is actually in the field seeing patients.
yeah,
But when you look at the IMG pathway, the turnaround is much shorter. These foreign trained medical graduates, many of them either have been practicing for years and are here and looking for opportunities, or they've gone to a U.S. residency program and within 3 to 5 years, they're highly skilled and capable to be seeing patients. And to your point, they're more likely to go to a rural or underserved area than a U.S. counterpart.
yeah,
So I talk about this in meetings all the time to say this is an untapped pipeline that can really help address these shortages. And it's incumbent on all of us to be educating, when I talk to lawmakers, their constituents to
yeah.
leverage this opportunity. And you never know, you might find an IMG that wants to be there for the next 30, 35 years. And that is an incredible win for the community, both health on a healthcare side, but also economic.
Yeah, definitely, definitely, and because I've seen like a lot of legislation put forward in in Washington, and I I've noticed like some people talking about it, but I haven't seen like the urgency. But I'm seeing the urgency from the states. All the states right now are just like pushing bills, granting licenses to IMGs with no GME requirements. Some are saying like home GME requirements, licenses. Just really laws. Just going out. I think so. Right now, it's 20 plus states that have an IMG law. So are states saying that? Oh, like are states feeling the shortage really bad, and are they saying like, hey, like we can't wait for Washington D.C. to act, so we're gonna just like do something on ourselves?
So I look at state action, and you're right. It has exploded in volume in terms of the types of bills we're seeing at the state level. I think it's a reaction to the paralysis we've seen in Congress from
Yeah.
the lack of moving these bills, and not just moving these bills, but going through the process of committee hearings, marking up bills, like taking them seriously at a level that shows that there is bipartisan buy-in for them. And there is bipartisan buy-in, but because of how Congress has functioned the last several years, we're just not seeing that type of progress happen. And so that's why I think you see a lot of states that are saying, well, what can we do?
Yeah.
And then you see why these alternative licensure pathways pop up, because there's enough functions on the state side to get a physician practicing under the supervision of another physician,
Yeah.
and the need, and state lawmakers, both state senators, state legislators, their their districts and their representation is hyper local, and so they're engaging with these employers in a way that I think helps to move the needle on some of these issues towards we have to do something.
Yeah.
And that's the message that I'm always talking about with folks here in Washington, that we need to do something. And
Yeah.
these are the things that we can do. And it takes time here, but states know we're running out of time, and they can put forward things that help to incrementally move the issue forward.
Yeah. So how do you think, because there's so many, folks who care about this issue around the country and who are like advocating in these different states, how can those folks come together and maybe push Congress, talk to their representatives, talk to their senators, to maybe get something on a national scale?
Yeah. So I think some of the solution is how we first came together, which is find your allies and find your partners and band together to talk about these issues and to align on your priorities. I think one of the things that resonated from speaking with you and speaking with others is this how aggressive states are being on this issue. And there's ways to leverage that in the work that I do, but there's also ways that clients I work with are looking at what their states are doing and thinking, oh, well, we should test this and see if we can do this ourselves. And that allows them to be trying things while Congress is slow moving on some of these issues because of issues totally unrelated to these very serious issues.
Yeah.
So I co-lead a coalition that is focused on it, strengthening the Conrad 30 program.
Mhm.
And just quick background, the Conrad 30 program is a J1 visa waiver program for IMGs in residency. It waives the home country return requirement in exchange for 3 years of practice in an underserved area.
Yeah.
And so we, as a coalition, there's probably 50 or so groups in this. We advocate for that bill's reauthorization, but we also work on other immigration and IMG related health workforce bills. The Healthcare Workforce Resilience Act is one, the Doctors Act, and other issues around that.
Yeah.
And so there's a tangible coalition that's there that we could all be joining and adding to and bringing more diverse voices to. But if that's not a coalition that resonates, that's the first step is sort of banding together with similar groups and using your collective voices to get lawmakers and other bigger stakeholders' attention.
Yeah, man, that's really great work that you guys are doing. If somebody wants to join the coalition, is membership open? How does it happen?
Yeah, please reach out to me. We can, I can share my email here, or just you can find me at Eli Greenspan on Foley Hoag's website, and would be thrilled to chat because it's really important work. And what I've realized over the several years is just how many people are trying to figure this issue out. Yeah. And when you find others that get it, that like you and I, like here we are, we the health workforce shortages, like we understand how serious they are.
Yeah.
Now it's just trying to get the hook in with some of these lawmakers to make sure that they're committed to advancing some of these solutions, because as much as it's about the doctors and the struggle that they've had and the experience they've had coming all this way to practice medicine in places where U.S. physicians won't go, it's about patients, quality of life. It's about keeping patients out of hospitals, and that is the message that we're trying to get through on how do we address these workforce shortage issues.
Yeah, that's a really great point. And you also spoke about some of the clients that you help. And you said that you mainly help a lot of different clients, but talk to me about your clients on the workforce side. What are some of the struggles that they're facing on a day-to-day basis when it comes to finding physicians or hiring physicians?
Yeah, so I work with a lot of recruiters, folks that are in hospitals and health systems and practice groups, primary care practice groups. And a metric that I'm really drawn to from the recruiters is time to fill. If time to fill is long and you're not having a physician in that role that's seeing patients, that's building, drawing revenue, it costs the health system and the hospital money. And these hospitals, especially ones in rural and underserved places, are operating on razor thin margins. So if you can't bring down that time to fill, it's hurting the system overall.
Yeah.
I mean, that's enormous pressure, unfair pressure on the recruiters given the state of the pool that's available.
Yeah.
But it's a interesting metric to use when talking to lawmakers. That's like, here are these solutions. Here's how they lower that time to fill. Here's
Yeah.
how we get more high quality volume into the market to help fill these roles.
Yeah.
Because that is something that is driving health recruiters at hospitals and health systems to fill these, like, not just primary care roles, but specialty roles,
Yeah.
because that's what keeps different wards and hospitals open and everything.
Exactly. And yeah, I was just speaking with and Micah Matthews, who's the deputy legislative and executive director here in the Washington Medical Commission, and he was like he was on the podcast last week, and he was talking about, like, he said a lot of people don't know how many different specialties we need to function.
Yeah.
Right. So everybody's thinking about primary care, underserved, which is a great thing, but like we have a specialty shortage as well, and a lot of people are not talking about that. So,
And it's scary because if you need a cardiologist or a pulmonologist or a nephrologist, it's like you're getting into a very specialized area where a patient needs to see a nephrologist if they need one. And so that means that they're going to have to travel between an hour and 3 hours to do that appointment and that necessary follow-up, or else they'll end up at a hospital and it's, even more costly and problematic, and the outcomes are much more varied.
yeah,
So that's a really important point in the conversation here. And that's why I talk about all these solutions. It's like, if Medicare reimbursement is chronically low, you're going to struggle to fill roles in certain areas.
yeah,
If you're not training people thoughtfully or training enough people, you're not going to see them going into these hyper specialized areas, or for that matter, chronic primary care.
yeah,
So there's a reimagining of some of these things that needs to happen. But what's great about the IMG pathway and why we need to be thinking about leveraging that is because IMGs are looking for opportunities to practice somewhere long term, to take over practices, to be fixtures in their communities, and be successful in their and where they are. And so identifying and articulating where the need is, and then marketing those to IMGs is a very obvious way to me of how we address some of these rapid acute shortages.
yeah, yeah. Time to fill. Man, I love that metric. Kind of shows, like, what's really going out in the community, and I don't know if you have it, but it would be really cool to see, like, over the years, time to fill is probably going up and up and up, and every year, probably the graph is, getting expanded.
Yes, can definitely share that with you. And it cuts across specialties. And when you really get into it and you see which specialties have higher time to fills, you would like to think that we would be incentivizing more trainees to go into those pathways,
Yeah,
because that's what we need. It's like, uh, we need to be more thoughtful about how we're developing the pipeline. Some of it is about volume, but some of it is also the need, and where we can more rapidly address some of these specific shortages.
yeah, yeah, yeah. So, and that's really good. And I know you guys have a lot of data on this, and I'm really excited. Like, anything that you can share publicly,
Yeah,
would would
absolutely.
would be happy to put it down. Do you know, like, um from the surveys you do, like, which part of the country is just facing the most highest time to fill? Is it mostly in southern states? Is it western? Is it Midwest?
So I have found that there are most challenges in the, like, plains
Yeah,
states.
yeah,
Some of the rural western states, but also in the Delta region. So some of the Mississippi, Alabama, Arkansas, Missouri, those areas can struggle as well.
Yeah.
And it really can cut across a number of different specialties. But the more rural states, high Medicaid penetration,
Hmm.
um, you know, the primary care needs are especially high, and um, it's the physician pool is getting older, and
Yeah.
that creates a lot of challenges for how you fill some of those gaps.
Yeah, yeah. I think I like where I am in Seattle, Washington State. There was actually a study that was done. I think so. Half the physicians here in Washington State were like 60 and over. So
Yeah. And
that's pretty scary. It's pretty scary. Yeah,
it's scary because a lot of them recognize that they want to sell their practice or set it up for it to continue, and it's hard to do that because of policies in place, but
yeah,
also just finding somebody that is going to be there that wants to take over that practice too. I mean, it's
yeah,
and like it should be scary for patients. That would be, a scary proposition for me, and if I knew that my physician was looking at retiring in the next 2 to 3 years. I mean, that's
yeah.
only a couple more visits, hopefully, between that in that time frame.
Yeah, yeah, definitely, definitely. Yeah, and patients, like a lot of people are not speaking about the patient side of it, and we hear from people all the time. Hey, I can't. Like it's taking me 6 weeks to see my primary care doc. Sometimes 8 weeks. Specialties. Forget about it. So you'll be waiting for like a year to see a specialist. Um, and I think, as you said, coalition finding, coalitions who care about workforce issues, but also, coalitions who advocate for patients. Everybody coming
Mhm.
together and saying, hey, here's a solution, how we fix these issues. So is Foley Hoag, reaching out to patient advocacy groups on these issues as well?
Yeah, absolutely. We find the groups that speak to patients, but also speak to like community leaders in other ways. So, I just not to name drop, but I spoke to the National Rural Health Association. Okay,
Nice.
National Rural Health Association has a very interesting perspective of who they are working with and the types of issues they talk about. So, a big priority of theirs right now is all the changes coming in Medicaid.
Yeah.
And so, what I wanted to talk to them about was, well, how are these changes in Medicaid connected to the broader workforce issues? Because, like the Medicaid changes, everyone needs to be preparing for those in the healthcare system. But we also shouldn't lose sight of how those changes are going to compound workforce shortages too. And is there a way that we can be talking about both to reinforce that these issues are interconnected when we make it when we put more risks on hospitals with high Medicaid roles, and they're already struggling to find a variety of different primary care and specialty
Yeah.
providers, it's going to make it a lot harder for patients. And so there's a lot of art, like workshopping these issues so that we can be talking to patient groups and making sure that this is part of their messaging as well.
Yeah, yeah, totally agree with you, man. And I said, like always, I tell everybody, hey, wherever you can go to conferences, talk about these issues, because like I think so. The more we talk about them, the more we find allies, like you said. That's how like everybody gets well versed on it, because I feel like, yeah, there are some specialists who understand the issues, but there are a lot of people who are like looking for the solutions, and I think it's our responsibility as people who have seen this firsthand to go out and
Mhm.
share and do speeches, do like focus groups, whatever it takes.
Absolutely.
Yep,
Absolutely.
yep,
And you can lean, and just to like put a fine point on that is we can look at specific provider shortages. We could look at how there's an OBGYN shortage, and what does that mean for maternal health care? We'd be talking to patient groups that are focused on improving maternal health in this country, and bring their perspective to the workforce shortage problem, because they're undoubtedly talking about it too, but
yep,
to put a face on how these shortages are impacting patients, it does help to you know get a personal interest in this from somebody who can make a difference. Helping
Yeah.
them see how it could impact them or someone they care about is how you get lawmakers' attention to really care about these issues.
Yeah, definitely, definitely. And it's such a bipartisan issue, right? I feel like, because even like speaking with legislatures here in Washington states, from both sides of the aisle, everybody's like, hey, let's do this. This is important. You can see it from even the IMG laws that pass around the country, like red states, blue states. It doesn't matter. Like
Mm-hmm.
everybody is like having an IMG solution out there because I feel like it's such a bipartisan solution and everybody's behind. I just don't understand why it's not like what happened to the urgency?
Yeah, I really do think that there's a vocal minority, like a louder minority, that is opposed to some of these changes, probably because of the immigration component to this.
Yeah.
I often say this is a healthcare issue wrapped in an immigration issue, or the other way around. It's like there's things that prevent it from moving forward, but when I talk to Republican staff or I talk to Democrat staff, like my message doesn't change that much. I
Yeah.
talk about the healthcare issues, I talk about the economic issues, I talk about the economic impact physicians have in communities, and the Republican staffers and the Democratic staffers are all nodding along in the same way because they get it. And
Nice.
so it's arming those staffers and lawmakers with data and information to ensure they're you know standing tall on these issues, and honestly working through these coalitions to position these bills for a moment where they can advance.
Yeah.
And then it's having tough conversations with members who may have different opinions on some of these issues, but this is a unique issue where someone may disagree on some of the solutions, but they can't ignore the problem. And
Yeah.
that's what allows a lot of conversations to happen, is because at the start, we can both accept there's a problem, but we may differ on some of the solutions. How do we find some that can work for both of us?
Yeah. Very well said, Eli. What advice would you give anybody who's frustrated in policy advocacy work? I know you have a lot of experience, and probably you were frustrated a lot of times. So,
Yes,
what advice would you give people?
stay strong. I would say that when I started on working on some of the bills that I work on, someone that I'm still in touch with said this is a multi-Congress effort.
Mhm.
And that's a hard message to hear. It's a hard message to hear early because multi-Congress, each Congress is a 2-year session.
Yeah.
So we're talking about 4 to 6 to 8 years talking about trying to get something done. But when you get into it and you start to build not just your own credibility, but your knowledge and understanding of the different angles and perspectives to pull on these issues, you see how you can be a voice for good and be a voice that can bring other perspectives together. And
Yeah.
so there's multiple coalitions out there. If you're looking to get more involved, the barrier to entry, I think, is lower than you think.
Yeah.
That there's a lot of ways you can engage in a meaningful and productive way. I'm always happy to partner, and I think that there's a lot of staff and lawmakers who want to understand these issues better and how they're impacting different providers and patients. So, best advice is to get involved and to stay engaged.
Yeah. What if somebody, Eli, is not a part of an organization? They're like a regular IMG. They're a physician practicing. Is their voice like? How can their voice be heard, and how can they participate in the process?
So because I work with organizations and clients and things like that. But what I always try to do as part of the tools that I have is telling stories.
Mhm.
And that is a individual IMG level story.
Yeah.
And so if you're an individual IMG and you're not affiliated with an organization, but you want to get involved, I mean, like, if you have a story you want to share that you're willing to talk about, that especially adds to the points of these either alternative license pathways or the Conrad program, or how these changes to H-1B policy are going to impact you and others like you. Like those are the messaging that we can turn around and make the broader point while also putting a face to the issue, which I think is really important.
Yep, yep, and yeah, really excited to see where this goes, man. I think we're seeing a shift. I'm seeing the shift personally in the country. Like 5 years ago, nobody was talking about IMGs. But it's starting from the pandemic. It went everywhere, and people were talking about it. If somebody wants to participate or get in touch with you, how can they do it? Is it LinkedIn? And where are you?
Yeah,
Where can people? Is it the website
I
at
would
Foley
say
Hoag?
LinkedIn is a great way to reach me. I'm very accessible, sending me a message or connecting. I try to post on these issues a lot. I try to share things that others are sharing. It's a great space, especially if you're also active on there. Or shoot me an email. I'm happy to sort of find a way to chat through some of these issues there too.
Awesome. Eli Greenspan, everybody, policy advisor at Foley Hoag. Eli, thanks for coming on the show. Really, really appreciate it, man.
Thanks for having me, and thanks for all that you're doing.